Uh, Good morning, everyone. Myself, Dr. Pankaj, and welcome to Pedia Academy Pediatrics. We are discussing today the next topic of neonatal cholestasis. This is very important topic for upcoming NEET SS exam. So let's start with. Neonatal cholestasis is called as conjugated hyperbilirubinemia presenting during neonatal period. Basically, this is conjugated variant of neonatal jaundice, which is called neonatal cholestasis. Mostly, it is cholestasis means impairment in normal bile flow. So, like unconjugated hyperbilirubinemia, conjugated hyperbilirubinemia in units always pathological. So this thing we know. Okay. So we'll discuss pathophysiology of this conjugated hyperbilirubinemia, that is neonatal cholestasis. Okay. So to basic understanding of this concept, let's understand this anatomy. This is liver, this is gallbladder, and the bile flow through these things can manifest as neonatal cholestasis. If hepatocyte, like hepatocyte level, like at intrahepatic bile ducts level, bile canalicular level, membrane transport level, or large extrahepatic bile duct level. So basically, it is anatomical classification of this cholestasis, which can be seen as large extrahepatic bile ducts, structural abnormality or obstruction. As we can see, this can be seen. Intrahepatic bile ducts obstruction can leads to cholestasis. Bile canalicula's functional disruption of bile transport, membrane transporters on hepatocytes, defect in bile excretion, and hepatocyte intrinsic cellular abnormalities. Okay, this is the beautiful table or chart from Nelson, which classifies neonatal cholestasis into extrahepatic or intrahepatic. Basically, either the problem in the liver or in the bile ducts outside the liver. If it is outside the liver, then biliary atresia, choledochal malformation, and gallstones and sludge. Biliary atresia is most common among them. Okay, so extrahepatic causes are most common. Intrahepatic causes are bile duct paucity, decreased canalicular flow, dysfunctional plasma membrane transporters, and hepatocellular injury, which can be due to various causes, infection, drugs, inborn error of metabolism, or idiopathic neonatal cholestasis. Basically, this flow chart simplify the classification into hepatic or extrahepatic. In extrahepatic is most common. In extrahepatic, biliary atresia is more common. Okay, so how you will approach the case of neonatal cholestasis? As we seen, evaluate each level of biliary system at anatomical level. If it is extrahepatic obstruction, we have to go for sonography, USG, hepatobiliary scintigraphy, and MRCP. If it is intrahepatic causes, we have to go for genetic or metabolic disorders. If it is cellular or membrane level dysfunction, we have to go genetic testing, advanced hepatobiliary function assays. So this is actually table from Nelson, which is a neonatal liver failures DDR displayed. First is GAL, that is gestational alloimmune from liver disease, HLH syndrome, mitochondrial liver failure causes, viral and ischemic. This is very exhaustive looking table. Just look into the highlighted portion of this table. We will see ferritin level, which will be very significantly high, like more than 20,000 in HLH, and triglyceride levels are increased. There are many criteria of HLH, but if you found that ferritin level are very high and triglyceride levels are also increased, think of HLH. So this we sorted. And in gestational alloimmune liver disease, you see for alpha fetoprotein levels. If they are increased, you have to think of GALD. Again, mitochondrial, we have to see lactic acids are increased, and in viral ischemic, these are borderline. So basically, you have to differentiate between these conditions like GLD HLH and mitochondrial. Again, we have to go for etiologies and their respective investigations. I will highlight the important investigation from this table. For biliary atresia, MMP7 is soft marker. This is the current update and it is very important. Other investigations are liver biopsy. The investigation of choice is intraoperative cholangiogram. Allergy syndrome we will discuss in separate video. Ophthalmological evaluation, liver biopsy, and genetic testing for JAG1 and NOTCH2 genes which are responsible for this syndrome. Cystic fibrosis, as we all know, this is sweat chloride and CFTR testing. Next, membrane transporter defect, PFIC, progressive familial intrahepatic cholestasis. Again, we will discuss this in detail in another video. But for this purpose, just remember three genes: PFIC1, PFIC2, PFIC3, ATP8B1 for 1, ABCB11 for PFIC2, and MDR3 for PFIC3. This you have to remember. Hypothyroidism we will test thyroid. In this table, for galactosemia we will test GALT, tyrosinemia we will test FAH gene, and fructose intolerance we will test aldolase B. Basically we are evaluating the neonatal cholestasis causes in their respective investigations. For bile acid synthesis defect we will see alpha 1 antitrypsin deficiency, SERPINA1 gene we will see. Lysosomal disorders like Niemann-Pick disease, so Niemann-Pick A, NPC1, NPC2 for Niemann-Pick C type. Zellweger syndrome, PAX gene, and cholesterol estrogen Wolman disease, LIPA gene mutation, and mitochondrial hepatopathy like ammonia lactate, and gestational autoimmune liver disease, MRI, buccal biopsy, serum ferritin, and total iron binding capacity. Okay, so if the neonate presents with neonatal cholestasis, that is conjugated hyperbilirubinemia, we have to give nutrition support. This is very important. Energy should be more than 130% of required for age. Fat should be 30 to 50% of total calories. Protein should be 130 to 150% of requirement of age. Carbohydrate 40 to 60% of total calories. Vitamin A, if less than 10 kg, 5,000 IU per day, and more than 10 kg, 10,000 IU per day. Vitamin D is 2,000 to 5,000 IU per day. Vitamin E 15 to 25 IU per day. Vitamin K 2 to 5 milligram per day, and calcium meet DRI. So this was for neonatal cholestasis. We have discussed in detail the approach to neonatal cholestasis and relevant investigations. Important thing in this neonatal cholestasis part, the etiology, we will discuss in detail in separate videos like biliary atresia, like Ehlers-Danlos syndrome, like PFIC, progressive familial intrahepatic cholestasis syndrome. These are important topics and we'll discuss them in separate video. So till then, do like, share and subscribe. We will provide the best content and which is very authentic and important for your exam. So stay tuned and do subscribe, do like,